and welcome to this meeting of the Health Scrutiny Subcommittee, our last meeting of this council year. I need to read some housekeeping notices before we start. Can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting? There's no fire test planned for today. If there is an emergency evacuation, please take instruction from council staff present, and the assembly point is in Tudor Square. The meeting today is open to the public and is being live streamed via our webcast, and the recording will be available on the council's website subsequently. I would like to ask our committee members to introduce themselves first of all, please. I'll start with Steve there.
Councillor Steve Ayres, Deputy Chair of the Health Scrutiny Subcommittee.
Councillor Gail Smith, Councillor for Mosborough Ward.
Good morning, Councillor Kevin Oxley, Councillor for Mosborough.
Morning, Martin Phipps, Councillor for City Ward, Green spokesman for the committee.
Hello, Mary Lee, Councillor for Darnell Ward.
Hi, I'm Lucy Davis, Chief Officer of Health Watch Sheffield.
Thanks very much, and I'm Ruth Milson, the Chair of this subcommittee, and I'll ask our officers to introduce themselves as well.
Good morning, Deborah Glenn. I'm the Policy and Improvement Officer and support to this committee.
Thank you. And Deborah, do we have any apologies for absence this morning?
Thanks, Chair. We've got apologies from Councillor Dorndale and Abdeslam Mohammed.
Thank you. Any items for exclusion of the press and public? Not today. And I have to ask members if they need to declare any interest in any of the items of business to be considered at this meeting. None. Thank you. So we'll go on to the minutes of the previous meeting, which is in your agenda pack. I'll just give you a moment to cast your eye over each page for accuracy. Page 11. Page 12, 13, 14, 15 and 16. Are we happy with those as an accurate record of that meeting? Thank you. Okay. So, public questions and petitions. We have had a public question which the member of the public is not able to join us today and have asked that their question be read out. We're actually going to take that, I think, later on in the agenda when we reach the appropriate item, as it will relate to item 8 of the agenda. Right, so going on to item 7, we have Richard Bulmer, I think, to report to us on learning from Firshill Rise CQC inspection. Morning. So if you use the microphone and...
Does that work?
That's it, great. And just remember to turn it off again if you're not speaking, because it just helps the webcast. Thank you. So I can ask you to introduce yourselves. Thank you.
I'm Richard Bulmer. I'm Head of Service for Rehab and Specialist Services in Sheffield Health and Social Care Trust.
My name's Greg Hackney. I'm Senior Head of Service in Sheffield Health and Social Care. Nice to meet you all.
And I'm Heather Burns. I'm the Deputy Director of the Mental Health Learning Disability, Autism and Dementia team at NHS Sheffield, South Yorkshire ICB. And I'm here just in support of my colleagues for this item, because it connects to the next item.
Thanks very much. So we'll take your report, Richard, thank you, and comments from the others present. Yeah, thanks for coming. Let's hear your report.
Okay, this report is reflections and learning from some of the failings at Firshill Rise, which was a inpatient unit for people with learning disability and mental health problems based in Firshill in the north of the city. In terms of the history of this, I think we've said in the paper in terms of it's a 7-bedded unit and it treats people with learning disability and mental health problems. And in terms of the issues that came up with Firs Hill, I think at the end of 2020, before the issues that came, sorry, at the end of 2020, we sort of put in place a new management structure in Firs Hill, and what became evident with that is some particular problems. We had sort of a particular service user who'd been at the unit for a very long time, and we had concerns around the quality of treatment that was happening with that person. So at that time, we alerted the CQC to the concerns at Firs Hill, and we instituted an internal inquiry in terms of the support and treatment of that particular individual. And we've detailed the summary of that inquiry into that individual. Subsequently, the CQC came through to inspect the service, and that's the details of that inspection are detailed in the report. And that sort of found failings in all areas where the CQC looks into how services are managed and run. And then in addition to that, I've just reflected on some of the national concerns around inpatient units and the Trust's response to that. So some of the national concerns around inpatient and residential units for learning disability, but also mental health units. And people might have seen the Panorama inquiry recently into Edensfield in Manchester, and just reflected about what's happened with that. So that's the first part of the report, and I think that's just looking at sort of the learning and reflections in terms of what happened at Firs Hill and the failings that the Trust had with the running of Firs Hill, and looked in terms of the next part of the report is in terms of our response for that over the last 2 years. So I talked about initially there was a setting up before, and that sort of identified the failings at Firs Hill in terms of looking at a different management and leadership structure at Firs Hill, which we've built on subsequent to that. But I suppose firstly, so the key elements I wanted to sort of talk about, or hopefully highlighted in the paper, is firstly about accountability and sort of a recognition from the Trust that there was significant failings in terms of what happened at Firs Hill and needing to learn about that. The second one is about leadership and changes that we've made in terms of leadership at Firs Hill. So we've strengthened the leadership. We've recruited nationally into new posts into the leadership team at Firs Hill, and that's including recruiting experts, a new clinical director who's a consultant psychiatrist who's joined the Trust from Birmingham. Most recently, we've got a new matron who's joined the Trust from Lincolnshire, as well as a new general manager in the Trust, so strengthening that aspect of it. And then look in terms of quite a long report in terms of a long review of governance arrangements in the Firs Hill in learning disability services and across the Trust. And I think this is really important in terms of the learning that we've taken from this is across the Trust. And that's looking at everything from structures about how we're reviewing incidents to how we've got visibility of senior leadership in trusts, how we're triangulating information in terms of when information's coming into the Trust, how we're making sure that information adds up and is seen in terms of forming open cultures within the Trust. And then the next element of the report is about engagement, and that's how we're linking in with service users, families in the Trust, with learning disability in particular, and we've done a lot of work in terms of ensuring, which I think the next report will talk about some of that engagement work we've been doing specifically on learning disability, but on a wider range of issues in terms of hearing what sort of service users and families think about our services and influence the changes to how the services are being delivered. We, as a Trust, have developed a new clinical and social care strategy, and that's detailed in the report, and that's looking about how we provide a service which is person-centred, strength-based, evidence-based and trauma-informed, and that's been delivered across the whole Trust and all of the services in the Trust, and very relevant to learning disabilities services in addition to that. And then the final point in terms of the report is looking at the Learning Disability Transformation Project. So we did, as the report identifies, the CQC asked us to close the unit to admissions. But so as part of that, we've been through and are going through a major transformation project of learning disability services. And I know that's the second paper that's coming to the committee to sort of consider that transformation project. But that's involved, again, listening to service users and really working very, very hard to make sure that we can avoid people being admitted to hospital, which I think is probably one of the biggest lessons of all of this, is actually people being admitted to hospital isn't really the best place for people. It's how we can provide really good community services to support people at home. And I think one of the issues that we talk about in the introduction to the report is the changes in terms of where people are being treated. So we haven't admitted anybody for the last year into a specialist learning disability bed. Yes, we haven't got any in Sheffield, but in lots of places up and down the country, and historically, people have been admitted out of area, and so it's that issue about trying to make sure that people we're serving people in Sheffield. We've had a couple of people who have needed to be admitted, but have been appropriately admitted to our adult acute psychiatric beds. And the national guidance on managing learning disability is we should be mainstreaming people where possible. So in mental health, if you think about somebody with a mental health problem and a learning disability, they may well need to be admitted to a mental health bed if they do need to be admitted, and we need to try everything we can to make sure they're treated in the community. But likewise, if we had a person with a learning disability who needed a heart transplant or heart surgery, we wouldn't have a specialist unit for heart transplant surgery. We'd wanted that to be part of the mainstream services. It's not quite the same as that, I would say, in terms of there might be instances where people would need admitting. But very much the direction of travel nationally is about providing good quality community services. And the city and what we've been building on is some of the successes over the years about reducing the number of people coming into learning disability units for admissions. And over the last year, we've been very successful in terms of treating people in the community. So is it okay if I end there and open for questions for the three of us?
Thank you very much indeed. Open to members to ask your questions. Councillor Phipps.
Thank you, Chair, and thank you for the report. Just reading through it, I was wondering, what has patient feedback or service user feedback been since the actions taken from the learning of the CQC inspection? Apologies if that was in there. I couldn't immediately see it, so I'm just wondering what the feedback has been. And I guess secondarily, what has the staff feedback been as well since the actions have been taken? Thanks.
I think the next report that the committee is taking will talk a lot more about the service user feedback. But I mean, in terms of the service user feedback, we met with all of the service users who'd had an experience of the inpatient services at the time and took their views in terms of what their experience of the service was. And that sort of fed into the learning we've had in terms of how we provide better services. And I mean, some of the feedbacks there about all of our inpatient services is about ensuring that people have good activities, and we're making sure that people have meaningful activities during the time that they're in the units. But also about sort of the need to support people at home more. Again, that's sort of quite a key theme in terms of the feedback from service users. And I think we also, in terms of the particular feedback for some of the people who are in the units there, is a sort of a frustration that people were stuck in hospital for quite long periods of time. So we had the particular person we were looking at the report for, which is detailed here, had a length of stay of 2 years in the hospital, and a frustration about how they should have been supported to be moved into the community, and that likewise that support from their carers and families. It wasn't all. So some of the feedback we did receive from service users who had used the service wasn't all negative. So some service users did talk about actually being quite a positive experience, having time at the unit there, and even the report we've identified here, some of the service users did talk about that particular experience, being some staff who were very supportive to them and had a reasonable experience with that. In terms of staffing, I think we've got sort of, I suppose there's two groups of staffing maybe we'd want to talk about with this. One is the staffing who were on the inpatient unit, and I think they've had sort of quite a frustrating time in terms of the unit closing, and I suppose feeling sort of that's been quite a difficult process in terms of all the media coverage and that experience of that. We've worked very hard with those staff to give them service, to give them development and support them to work in other parts of the trust, and they're contributing across a wide range of different services in the trust. We bring that group of staff together on a regular basis for practice development and support in terms of their experience with it. I think one of their frustrations is about the longer term future of the unit. There's actually quite a lot of those staff have actually left the units subsequently and got jobs in other places, but there is still some staff who are seconded into other parts of the trust. I think their experiences, is been positive in other parts of the trust, got good support, and one of the things we talked about in terms of the failings of the unit is we weren't providing good supervision and one-to-one support for staff. That's dramatically changed, and all of those staff are having regular supervision and being kept in touch with. So there's that group of staff. And I think then the other group of staff is the staff in the learning disability community services. And I think sort of they've experienced sort of the change in services in terms of the strengthening some of the clinical leadership in the services quite positively. And we've been successful in terms of recruiting new staff into that service and eager to move on to the next steps of further developing community services in the city.
Thank you. Councillor Ellis and then Councillor Smith.
Yeah, just one question. Thanks for the report. We may touch on my question under the next report, but I'm looking at on page 25 where it talks about the Learning Disability Transformation Project, and it says that the evidence from project groups consider best practice from other services nationally. Just wondering how specifically in relation to learning at Firs Hill, to what extent best practice might inform the future model at Firs Hill effectively.
Yeah. Yeah, thank you.
Could I answer? I think it's a really good... Can you hear me? All right, sorry. Yeah, the evidence base is absolutely crucial. In my later report, I referred to something called Building the Right Support, which is a national model and template. I think one of the biggest things that's emerging over the last 5 years is that there are alternatives to needing to admit people into hospital, because often the sorts of hospital that we're talking about is when people feel they've not got any other options in the community and something's broken down, either at home for the family or for a care provider. And then in terms of best practice, what best practice would be saying is, let's try to keep people in the least restrictive place and closest to home. So what we have been learning, not just nationally from best practice, but also what we've been doing in Sheffield, but South Yorkshire as well, is about what are those components in the community that are best practice to support people. And that is around having enhanced services. At the moment, we've only got Monday to Friday community services for specialist learning disability support. So if somebody goes into a crisis out of those times, they're more likely to end up in the wrong place. So part of that best practice and evidence is learning what works in community settings too.
Thank you, Chair.
Councillor Smith.
Sorry. Thank you for the report. It's uncomfortable to read. I wanted to ask, do you think that there was a distinct lack of training for the staff? That's one question. And I wanted to ask, why was someone there for such a long time? How did that happen, and why?
I think in terms of the training, I think we've identified in the report we needed to do more in terms of training for staff. I think there was some training that took place there, I think, but once we've looked into it into more detail, I think sort of finding we needed to do a lot more training in different models in terms of how we provide services for staff, and that's training that sort of that's one of the actions that we've done with the staff who are working there, but also supporting the community mental health teams, working with learning disability to do that work. And the second question about why did the person have such a long stay? I think it was wider than the unit. I think it was challenging to find placements for the person who was in the unit. Now I think there's a failing that the trust had in terms of how it escalated and pushed that, and I think we should have done more in terms of that aspect of it. And I think there's also something about once somebody got into hospital, it's a safe place, and I think people sort of are seen as a safe place, and I think this demonstrates actually that's a real question about whether being in hospital for that length of time is a safe place. But I think that so somebody getting into hospital and then getting stuck in hospital, it became quite difficult for them to get out of that place, and potentially even institutionalising people by getting them into hospital like that. So, so I think it's a wide system sort of problems and failures with that, and actually some of the learning in terms of some of the working we've done subsequently with that, with one is avoiding hospital admissions. And I think there was an issue in the city, probably the Christmas before last, where somebody was potentially looking to get admitted into a specialist unit. We worked very widely. I think it was a Doncaster resident, but it was a complicated set of circumstances, which I won't go into the details of it. And that probably isn't appropriate in here, but the issue was around about making sure that we were working really hard as a system, working with the local authority, working with Sheffield Place, working with colleagues in other trusts, about making sure that their need to be admitted was taken really seriously. And actually it was probably the social care failings that were leading to a need for admission, and working really hard to get those social care provisions in place to stop the admission from happening.
I'll just add something. I think that the person that we're talking about for 24 months was placed by another, at the time, clinical commissioning group into the service. There was a complication that the person had been elsewhere, so there were kind of two authorities overseeing. Now, since those times, at South Yorkshire Integrated Care Board level, we do 6 weekly safe and well checks for anybody in a hospital placement. Those checks were happening before, but as Richard said, these are often people with multiple complexity and finding the right provider. So when you talked about social care failings, it's not that social care are failing, it's the difficulty in finding the right providers in the community. And Andrew, my colleague here, is working really hard and well across the system to look at how do we get the right providers into the city with the enhanced framework that the council have put in place. We've done that before across South Yorkshire as well, but it's brought some new provision into the city, but still not enough. And particularly we're looking at children, young people coming through the system who are presenting with, severe behaviour that challenges services to support, and what we need in the city going forwards. I'll talk a little bit about some of those plans in my report as well.
Thank you. I've got Councillor Lee and then Lucy.
Thanks. I guess a couple of questions. One is about the staff that were on the unit that remain in the trust. You meet regularly with them and they have extra training and meet with them for supervision and other to discuss whatever you discuss with them. I'm just wondering if the patients that were in that unit have had the same opportunity to meet regularly as a group with the right people to discuss their experiences and to work through any trauma they experienced at the time. So that's one question. And I'm assuming you've talked about this new framework now. This is going across the trust. Does that mean it wasn't there before, or not applied as vigorously as it should have been? I guess that's the other one. And in terms of putting people with a learning disability on an acute psychiatric ward, which can be very disturbing, are we sure we've got the right, you can put in the right levels of support for that person who might need extra, given all that happens on an acute psychiatric ward, that they might experience, and they are very, very vulnerable and prone to exploitation, possibly. I just wondered if that is, you've got the right measures in place, and people have got the right training, because nurses on psychiatric wards don't necessarily understand the difficulties people with a learning disability experience.
I'll try and get all three of those. I think the second one I might just need reminding with. The first question about the service users. So all of the service users, once they were discharged, have been sort of supported through sort of the community learning disability team. We wouldn't necessarily bring that group of service users together. They wouldn't and if you think that service users, that group of service users would be changing on a regular basis. But what we have done with those service users, we've worked with an external organisation called Respond, which is a national organisation which supports people with trauma-informed care. And where that's been identified as necessary, those particular service users, we've supported them through specific actions with that. So they've all had individually tailored support in terms of subsequent to the discharge from the hospital. And all of their families and the service users were met with, not just by their community learning disability team, but also by sort of representatives from the trust in terms of sort of learning and speaking to them and giving them a place to talk about their issues. Now, so if you just probably just a quick reminder of the second bit of the question. Yeah, across the trust, was it not them or not as rigorous? Yeah. So I think we've got to say, in terms of from the wider trust perspective, at this time, so I think this was probably the end of the trust, which was rated as inadequate at that time. So I think there was some failings across the whole trust, and the trust has really reflected very hard about those failings in terms of looking about how we can change practice with that. So I wouldn't say all of those things were not in place at the time. Certainly they've been strengthened since then, and the trust overall has moved from an inadequate state from the CQC to a requires improvement, and we're on a sort of a journey through to good and pushing towards sort of, well, we want to be an outstanding trust, but we're obviously on a journey in terms of that sort of place. So those learnings have been extended across the wider trust, and I think it was probably different in different parts of the trust. One of the things I would say about the Learning Disability Service, which was quite unique, and not completely unique, is it was a unit as a standalone unit in the trust. So while it was probably more prone towards a closed culture, I'm not saying necessarily that way of working, our other services or alongside other services that can sort of learn from one another more about that. And we've tried to make sure that all of our service have access to sort of external review where appropriate. So we're looking at accreditation through the Royal College of Psychiatry for many of our services where that's an option, and particularly around our options that are perhaps a bit more isolated. So we have units at Forest Close, which is now Royal College accredited, next to a forensic unit, and they're standalone units, but that and the forensic unit is being reviewed by the National Forensic Services, so sort of just in terms of making sure that external review to support some of those services. And the third part. Yeah, and so what we're doing in terms of, it's where that's appropriate. So if somebody needed an assessment and treatment service, we would be looking at accessing that externally to the city, but where that's appropriate. So the Green Light Working, which is the national objectives national way of working with people with learning disability emphasises that people should be in mainstream services but properly supported. And one of the things that we've built around anybody who's been admitted to, the two people who have been admitted to psychiatric wards, is the support that they get is the learning disability specialism in reaching into that service on a very intensive basis, where we get psychology with learning disability expertise, psychiatry with learning disability expertise, and nursing with the learning disability expertise, going in and working with those teams on a very regular basis to make sure that we've got the right support in place for those people.
And just to add to that, really, so the emphasis for us as an organisation is on working in a very person-centred way, and that's part of our clinical and social care strategy. People with a learning disability have a right to be able to access mainstream mental health services where that is clinically appropriate, and we're working in that way to make sure that our service offer is needs-led and on the basis of what that individual needs. So if we assess that that person does need a short period of admission within a mainstream acute mental health unit, then we would make the adjustments that are required for that person to be accommodated in that environment. And as Richard's articulated better than I can, that does involve a lot of specialist support in reaching to enable that person to access the care that they need. And obviously that would follow the training requirements for our staff group in that environment to ensure that they're suitably skilled and able to meet the needs of that individual.
I think it's I'll respond to the last question, Councillor Lee. From a quality review perspective, this is something that we've actually formally asked SHSC to respond to, particularly around the needs of people with autism when admitted. Because don't forget, when we're talking today, sometimes we're just talking about somebody with a learning disability who also has autism. there are also people with autism without learning disability that are going through these pathways. And so and that is more of an emerging population in need, and particularly through the pandemic, presenting in crisis. So we're investing some capacity into the Care Trust around what we're calling at the moment an autism crisis nurse. That person isn't there 24 hours a day, but they're there to give further advice and expertise to some of the other community mental health teams and the inpatient wards. I have a member of staff within my team in the Integrated Care Board who's got a nursing specialism in learning disability and autism. And whenever there's a potential admission, we have to do either a care and treatment review or an emergency review, which we instigate from the Integrated Care Board with this member of staff that I have in my team chairing that review in order to avoid that admission. But part of that process is saying what is the best place for this person and identifying any gaps. So if somebody does go into, say, mental health ward, then it's monitoring the progress, and if gaps around knowledge are picked up, then that's something we would work with Greg and his team to address. But I'm meeting the acting chief nurse to look at the autism training into the Care Trust. It's something I feel fairly passionate about. But you've made a lot of progress this last 6 months to 12 months as well around some of the training that has happened. As well, the Care Trusts have got an intention to improve and are doing massive amount of work on the wards, which means that there will be sort of some quieter spaces and not the dormitory spaces of old. So that's part of the improving the offer for people when they're admitted. But the key is to avoid the admission unless it's absolutely clinically necessary. And as Greg said, that's a kind of a person-centred decision and approach.
I'm just going to leap in myself and just ask a little follow-up to Councillor Lee's questions. So with patients who have been admitted to an acute ward, what's the sort of, how is the process working for discharge, and how is that different to the experience they would have had at First Hill?
It is challenging for the reasons I outlined earlier around getting the right provision in the community. And that is often around the quality of a provider, how competent they are at the skills that they say that they have to support people in, with specialist needs in the community. Our ability as system partners across health and social care to monitor those placements and review, and then our ability to respond when things start to spiral downwards, when maybe there's an escalation of behaviour. So it isn't easy to get people out, both people, if I just step outside learning disability, people with a mental health condition or people with autism or people with learning disability into the right provision. But part of the care and treatment review process that I've just mentioned is bringing together multidisciplinary teams, multi-agency teams. So Andrew's social workers who have got real specialist skills in learning disability and autism, and working with the Care Trust's community learning disability team and community intensive support team to sort of come together with best options, and then we try to pull together the majority of people we can place, but there are the odd individual every so many months where we really struggle and have to come together and come up with some solutions. But partly the work that the council's doing on trying to get new providers into the city is one of the things that we're trying to do collectively to address that. It can be challenging.
So are you happy that patients for whom it's difficult to find an immediate discharge path, are you happy that they're in an appropriate, safe place? A safe environment that is going to nurture the progress that they've already made through the treatment?
Yeah.
Or, is there a danger that stopping in hospital for too long is a backward step?
Absolutely, and that is, again, part of the kind of ethos behind the work that we're doing that I'll be going on to talk about around trying to get that improved support in community, more intensive support in community, ability to support people to prevent the admission, but then if they are admitted, to quickly get them back out. And it is about, I kind of think of discharge as actually, if we don't think about discharge, as in pushing somebody out, but we talk about pulling somebody back into where they belong, I think that's the main focus, and that's what working with local authority colleagues and the colleagues in the care trust and members of my team, we try to do effectively together. There is always a risk on some, particularly people with learning disability and autism, if there's been a very, very problematic situation that's led to the admission, often the provider will say we're not having them back and the person loses the tenancy. And so that itself becomes the risk that you're outlining around a longer length of stay than people would desire. But that's part of the process, the transforming care processes that we've been working on to really try to wrap around. And sometimes it is hard, definitely.
Lucy.
So I suppose first to acknowledge that although this has come from not a great place, there do seem to be some really positive sort of actions that have come about as the result of some of the unfortunate sort of history of Firs Hill. And I think that broadly the sort of direction of travel is one that's supported by the people that we talk to in the who have got learning disabilities. But just to sort of unpick a little bit some of the sort of detail to some extent, and I know we're coming on in the next paper to talk about future options. It's quite hard, isn't it, to work out what we should sort of say here and in the next bit. But to a certain extent, obviously that service has already been disinvested in. It's been closed for quite a while. The staff have been dispersed, and you've described a number of things that have been done to kind of build skills and capacity in the trust. But what I'm really trying to get my head around, and I don't know if it's me just not sort of understanding or picking it out, if I was a person with a learning disability living in supported living right now, what support would be accessible to me for my mental health that wasn't there in the community sort of 2 years ago when Firs Hill was closed? So how is that resource being used right now to provide that additional support? And I'd just like to hear just a little bit more about that to kind of bring it to life a bit, rather than the sort of the way that the structure's been invested in and so on, which all sounds really good. And I know there are some really positive, you know, the team has sort of really been strengthened a lot. But what does that look like for people is what I'm interested in. And the other thing was just to follow up on the sort of thing about the autism. And again, I was going to pick this up in the next one, but as it's come up in discussion now, I'll sort of quickly say it. So although Firs Hill wasn't there for people who were autistic without a learning disability, we know that in reality it was sometimes used for some of those people in sort of different ways. No, am I wrong about that? Yeah. Okay, it would have. Okay, so so that's my misunderstanding. But nevertheless, I would be really interested to sort of see further work being done, really specifically to get feedback from individuals who are autistic, who are accessing mainstream services, because the bits of feedback we have had, not just in relation to sort of mainstream mental health services actually, but generally in relation to most hospital environments, is that those are really difficult environments for a lot of autistic people. So just, I know it's already been discussed, so really just to make the point that really specific feedback from that group as you sort of make those changes and developments would be really good to see and hear about.
Shall I take the first question just in terms of, I mean, I think in terms of the offer that we were able to offer now in the community that we weren't able to offer beforehand in the community, it's limited in terms of any additional resource we've got into the community there. But what we have done, I think I talked about sort of some of the expertise that's come into the team in terms of changing the structures of the team. So I think in terms of the way we work with people now, due to the increased psychiatry input, a different way of working with the psychology team and the nurses, means I think that the teams are getting a better wraparound of multidisciplinary team working, so the team's functioning better with those people. At the moment, there's no new resource coming into that, and that's the next ask, I think, in terms of what we're looking at, what we might do with the resources that may or may not be freed up with, depending what the outcome of the engagement stroke consultation is with that. But we think we can offer a lot more in the community with increased investment in the community. I think we are offering a better offer because we've got better expertise in the team, but that's not new resource into the team and different ways of working.
just to add to that, Chair, so part of the issue about people with autism is that the Community Learning Disability Service doesn't work with that group of people. So traditionally, and as Greg outlined earlier, people have accessed mainstream services to varying degrees of outcomes and success. So I mentioned earlier that autism nurse. That's one of the posts that I think is a critical investment for advising when somebody does go into an admission into the mainstream mental health ward, to make sure that they're sort of being supported better around their autism. So that's one thing. The community intensive support team, it was a stepped model where they're there to try to prevent that admission for people with learning disabilities and autism, as Richard said, in terms of investment, this is where we want to move to next, in terms of we haven't taken money out of the system. That money is available to reinvest, dependent on the outcome of the work that I'm going to be talking about, into services, because we recognise we would like to enhance those services, particularly weekends and evenings, when after that specialist team's gone home, people are just then into the sort of generic mental health services, and that's something that we want to address. It's small numbers that might come through, but potentially big kind of crisis, so that's what we want to address.
I don't know if I could just add to that as well. And obviously, some of the data that's included in the paper on transforming care is evidence, the changing need for specialist provision. As an organisation in SHS, we've done a lot of work within our quality directorate, and that includes employing people that are neurodiverse, so people who identify as having autistic spectrum disorder, to really help us to look through the eyes of people with autism that might be accessing either our acute ward or specialist provision. Also, some of the work that I think Richard mentioned about we've employed people who have expertise in learning disability, such as the consultant psychiatrist, and they're really driving home initiatives such as STOMP, so stopping the over-medication of people with a learning disability. And we haven't got that information available today, but happy to share that with you about some of the significant improvements we've made around reducing the use of psychiatric or antipsychotic medication for people with a learning disability. So I think the experience for people right now will be a significantly improved experience compared to where we were before. And one of the previous questions was around the partnership that we have with the local authority, and being clear really about what the offer is from a health provision and what the offer is from a social care provision. And I think that partnership is much better than what we had before, and will be further enhanced through the work that we're doing around the engagement piece that we'll talk about in a moment. So I'm confident in saying that the experience of people with a learning disability is now significantly improved from where we were. We absolutely have more work to do, and I think that is what we'd like to talk to you about in the next item. And again, I think we're returning in May to talk about that further.
Councillor Oxley.
Thank you. This was a very hard read, but then I can appreciate how much work that you've done in terms of taking it to where it should be. Two questions really, and to some extent you've touched on them all already. There's no mention in the report in terms of the outcome of those patients that were at First Hill. So just for my reassurance, and I think for the public's reassurance, I'd like to know that they are now in a better place, receiving the care that they need. And the next question is, thinking about people with learning disabilities and with autism, mental health, how has this enabled you to look at other services within the trust that those people will be accessing, and what learning can we make within the wider trust in terms of how we deal with those people?
So just in terms of the outcomes for the people who've been discharged and their sort of next steps with it, I can't go into the details of all of those people, but what I would say is all of those people are being followed up by our community learning disability team, or the relevant community learning disability team if they've come into Sheffield from other areas. And looking at, in terms of people's readmissions to hospital, we haven't seen that group of people being readmitted to hospital. And as I said before, in terms of that initial, once people were discharged, the Trust worked with all those people in terms of not just the community mental health, community learning disability team, but also in terms of wider questioning, working with families about that. So that, I think that's in terms of hopefully have some reassurance about those people who've been discharged from the hospital. And the second question, just the
how can we learn from this across all the other services that we deliver to make sure that the experience that these individuals get if they go to any other clinic or access any other service, that there's an awareness within that service of the needs of people with... Sorry, I will do. So how can we learn from this to ensure that when patients with these types of disabilities or issues, that when they access all our other hospital services, that there's an awareness within those services of how to deal with these types of individuals who will obviously have some very special needs, so that equally they are not, I don't want to say treated badly because I can't think of the right words, but to make sure that they are treated appropriately within those different other services. And I know that's a big ask, and that's, but...
So I think there's two bits of that, I'd say. The first bit is, if we talk about learning disability service users and they're accessing other services in mental health services within the Trust, I think it talks about the Green Light tool working, and that's a sort of a national programme about saying when people have learning disabilities, they need to be supported into mainstream services, but that isn't abandoning them into mainstream services. It's very much about how we have wraparounds those people. So if we have somebody from our service who needs to be admitted to a psychiatric ward, or indeed, it wouldn't necessarily mean that everybody with a learning disability would need to be in a specialist learning disability mental health team. It might be appropriate that they're managed by an early intervention service, but we've got facilities to make sure that our community learning disability expertise will go with those people and wrap around and give the staff who are working with those people the right sort of levels of experience with that. So I think that's the first part in terms of how we're working to make sure that we're delivering the right care for those people. And the second bit, I'd just say in terms of the Trust has developed the clinical and social care strategy, and that's specifically looking about how we work across all of our services, and those components of person-centred, which Greg talked about making sure any individual within our service we're working towards them as an individual and they're getting the right care. Strength-based, and that sort of, again, not assuming that everybody's coming into our services, we're just working with people with a disadvantage, we're working with people who've got their own strengths, and that's particularly with people with learning disabilities that've got a lot to offer and a lot to contribute. Evidence-based, and that's making sure that when we're looking at the research in terms of how we're changing services across all of our services, and then trauma-informed, and what we know with a lot of the people with learning disabilities, and probably 99% of the people who come into our secondary care services with learning disabilities, they're going to have subjected to some kind of trauma in their early life, and how we make sure that trauma-informed care is looking about how we support that. And that's the model we're using for trauma-informed care routes, which is looking at both how we make sure that the service users are getting the right treatment, but also that the staff wrap around for that, so we're getting the right supervision, we're getting a culture which in the organisation is psychologically safe, is looking about making sure that we learn lessons across the system, and that's all part of that, should feed back to the individuals for that.
I'll pick up your question about wider hospitals as well, because I think that's really important, although not directly related to this, but it's part of people's experience, isn't it? So within NHS Sheffield Integrated Care Board, we host a physical health improvement group, and that group is made up of partners from all health organisations and primary care and social care colleagues, and we have a number of projects that are aiming to improve people's experience of accessing healthcare. So just a couple of examples. A piece of work that I had reported back to me yesterday, we've seen a 19% increase in women with learning disability accessing breast screening in the last 6 months because of a piece of work that we've done. We've had, I think it was a 28%, I'll need to come back on that figure, 28% increase in access to bowel screening. The reason I'll come back is because I'm quoting it back from December and it may well have changed since then. And this is through the work that members of my team are overseeing with partners around trying to improve access and quality of access. The teaching hospital now have got employed directly learning disability nurses. In fact, they kind of pinched them from them and me because they were doing a piece of work for us. But that's really positive because that person's worked both in the learning disability service, in primary care, working for us, and working into now the teaching hospital to really look at people's experience of when they come into hospital. And she sits on that group with us, as indeed does one of the nurse directors to sit with us. But you're absolutely right, people's experience can be variable because if somebody, say, is non-verbal presenting in hospital, it's very difficult for staff to really understand. We do things like, Councillor Lee, you know about the hospital passport and the health passports, where we try to put that in place for everybody that goes into hospital to understand their needs a little bit more. So there's a lot of initiatives around this, but you're absolutely right. This population still struggles with accessing both primary, secondary care and mental health care.
Councillor Lee?
I just want to say, you know, obviously you've put a lot of hard work and developed a new framework and implemented it across the trust. I think that's brilliant, absolutely essential, and it's really good work. I just think, you know, there's more than that, isn't it? Looking after people with a learning disability can be the hardest job in the world, and we need all that in place to make it an easier job to do. But it's fundamentally, it's about values and optimism for people with a learning disability. You haven't got an optimism there to say they can get better, they can do more, they can achieve more. If you've got that inside, if staff have got that basic belief that drives them, and I'm sure you all know about this anyway, so I just for the record, I think that is really, really important, and it's something inside rather than a set of rules or framework that we all live by and work by. So I guess that's, and I think staff can come in, new staff can come into a unit where perhaps those values are not there and can be quickly contaminated by the ethos of an institution or a ward. And even in the community that can happen as well. So we've got to continually make sure that we're working to improve and maintain those standards. And I know you know that, so I don't want to teach my grandma how to suck eggs, you know, but it's worth saying. Thank you.
Thank you. I've just got a few little questions about the governance part of your report. Just a few little bits that I find interesting. There's one thing listed, improved visit schedule for board members to meet service users and staff on site. So I just wonder, is that already happening? And what sort of outcomes have you had from that already? Is there, you know, a new level of kind of knowledge and understanding that's coming out of that? And the lived experience work opportunities to be developed across service lines. I think that's really interesting. If you could just say a little bit about that. And the freedom to speak up model, developing with champion roles to enable better coverage across the trust. Is that a new model? How is that being developed across the trust? And was there some kind of framework in place for Firs Hill staff to speak up during the period that's been examined? And did any staff raise concerns during that period? Was it easy for them to do so? How was that handled?
So firstly, the board visits, and so that's a programme that's now been established where the board members go out on a regular basis, on a planned basis, to meet service users and services. So go out and actually spend some time with people, talk to people who are experiencing using our services and the staff who are delivering it frontline, so they're not hearing it via me or by one of our senior managers. And what happens with those reports is, after those reports, the team then gets sent a summary of the experience of the board members, which I think often is really positive. So that's often sort of highlighting some of the things that Councillor Lee was talking around culture and about sort of looking at those issues of you know, are people talking about hope with the service users? getting that information back to people, which then sort of feeds in through various other governance arrangements in the different teams. The freedom to speak up model was in place in the trust at the time, but that's been really strengthened. So actually, I think there wasn't issues raised through freedom to speak up at the time, but I think there was concerns that we probably should have seen at the time, and we should have been able to respond to sort of 2 or 3 years ago with that. But the model in terms of the freedom to speak up has been very much strengthened, and the freedom to speak up guardian, which is the lead person who goes into teams, has been into that team, but also goes widely in the trust to talk about the work that they do. People can raise concerns confidentially, and that's then we, as a sort of senior leadership team, will look into those concerns and feedback through the freedom to speak guardian about what we've done about those concerns. The person who's made those concerns isn't known to anyone in the senior management team about what's happened with that, and that sort of scheme works well with that. And the third point you raised was peer support and service user experience. So the trust has been one is we welcome applications from anybody in the trust who's got experience of mental health problems or learning disability or autism. That's now very much explicit in all of our adverts we send for all posts in the trust. But we've also looked at developing roles which are specific for people who've had lived experience, and that includes sort of peer support workers in a lot of our different teams. We talked about in terms of, I think we touched on in terms of the paper, in terms of the transformation work that we've done. That transformation work's been jointly chaired by a person with lived experience and a professional, the psychiatrist, clinical director of the service. So that lived experience work is very much at the core of how the trust is sort of pushing forward in terms of its developments.
If I could add to that, really. So across the whole organisation, obviously we're here to talk about learning disabilities. We're trying to adopt that culture of critical curiosity and inviting alternative views and perspectives on the way in which our services are run. And I think that is a theme that came out of the learning of Firs Hill, is the closed culture that existed and the absence of that curiosity. The positive recruitment campaigns that Rich has talked about employing people with lived experience is part of that piece. We've also done a lot of work with the Care Quality Commission around something which we've called the Fundamental Standards of Care. And it's a programme of work which we're rolling across all of our services to almost imitate inspections into our services from a separate part of the service in order to invite that alternative view or the perspective to try and avoid any closed cultures developing. I think Richard summarised that, but I just wanted to emphasise the work that's going on elsewhere within the trust to avoid a reoccurrence of what we learned from Firs Hill.
Thank you very much. Anything further from members? Okay, so thank you very much for bringing the report and answering a lot of questions. So that's been really useful. Thank you. I think we are asked to note the issues raised in this paper and consider, in line with the work to rebalance and modernise the provision and model of community services to support people with learning disabilities and their families in Sheffield. That's quite a complicated one. Are we happy with that, members? And I think to add to that, Lucy's request that there might be a report back on feedback from people who have used this the mainstream services, to hear some of the feedback from them. I think we could probably receive as just a written report by email, if that could be distributed to the committee, and we'll make sure that gets to you, Lucy, as a member of the committee. Is that okay?
We'll try and pull something together with that. I'm not sure we've got sort of a formal report on that, but we can pull together we can ask some questions in terms of those people who use mainstream services and pull that back.
Okay, thank you. Great. Thanks very much for your time, and I think Heather's probably staying put for the next item. Okay. You're staying put. Brilliant.
Thank you.
So, colleagues, we've covered some of the issues because there's clearly an overlap with them.
Introduce.
Oh, sorry. Richard.
Oh, sorry. I'm Richard Kennedy. I'm an engagement manager at NHS South Yorkshire.
And Richard's been working on the engagement programme that we're here to outline. So we came to you in December to talk to you about the future shape for community learning, for learning disability services in Sheffield, which obviously overlaps with the position around Firs Hill Rise. And you asked for us to come back with an update on the engagement work that we were doing. We're programmed in to come back to you towards the end of May to give an update on the next stage. But today is just to give you a progress report on how that engagement work has been going. So we've covered a lot of the issues. So the issue around, do we need as many inpatient beds as we did previously? We covered the success of the Transforming Care programme in keeping people out of hospitals through some of those processes that I've described, like the care and treatment reviews and the community teams and working with local authority colleagues. And then we talked about how we have an ambition, partly arising from learning from Firs Hill Rise, around how we should or could enhance our community services more. And part of that, getting to that position, is looking at Firs Hill Rise and the future need, the future options for that. So we've been doing a piece of work, and it's felt like a positive piece of work around engagement with people with learning disabilities, family carers, some of the staff that you talked about earlier, some of the staff within local authority, but also in the community teams, to seek their feedback on what services do people want in the community. And we've been talking about that being the sort of phase one of the engagement process. So we worked with a couple of organisations of people with learning disabilities themselves to help us formulate some questions to go out to talk to other people with learning disabilities about. And then did a number of engagement events. So some of that was face-to-face, some of it was group work, some of it was using art materials, some were surveys. And also we have sought people's views on what they need in their community services. So if you look at page 32, some of those outcomes and some of the summary of those outcomes are listed. And it is fair to say that people would express concern about anything that might change having a local hospital, and we understand that. So there's definitely people who've got concerns about if somebody's placed in a hospital outside of Sheffield, are they out of sight, out of mind? What are the travel arrangements? And actually, councillors, you raised that with us last time, and it is certainly something that we would need to be properly addressing in terms of any options going forwards. So we've received feedback overall from 178 individuals, which is quite a large number, especially given this is a very small population with a smaller subset of people with learning disabilities that would be impacted by any future changes. But that initial engagement has included carers as well, because that's very important. They're often the people that are trying to hold up really difficult situations at home when they've got sons and daughters whose behaviour is challenging. And particularly working with Sheffield Voices and Sheffield MenCap has given us a real way in to talk to people about their views. So they formulated the questions: what do people feel they need to keep safe and well? What support learning disability services could offer them? And what support would family members need? And I think in summary, people were saying yes, they needed more support in the community. They needed more consistency of support. They felt that, actually it picks up what Councillor Mary Lee said, it's about the people offering that support and their underpinning values. They felt that if people did need to go into hospital, it needed to be a therapeutic break, and that picks up the question that I think you asked Councillor Milsom and yourself, Councillor Oxley, around and Councillor Smith around surely 24 months in a hospital cannot be that therapeutic. So it is about the shortest available inpatient treatment in order to get back to normal life. They talked about people, and actually Greg picking up that staff at Firshill did get a positive mention around the care and support that they got from one particular family member. They felt that they needed more support from some of those generic mental health services that you were asking about earlier. And as we said, the Green Light Toolkit is a national programme for trying to improve the understanding of mental health services for learning disability. And they talked about a fear of being locked up or sent away, which I think is really quite a significant phrase. But they did talk about being worried about if people did go somewhere else out of the city. They talked about that stigma that still happens, and they talked about how their experience of being in a mainstream hospital in the past, because of the disability, people didn't know how to help them. So there are all those considerations that we need to take into place. I think in general, the position we're now in is we've gathered this information, we've talked to a large number of people, we need to try to move into the next phase, which is developing options that we can then talk to people further about. Can I just bring you in, Richard, there about that kind of process?
Yeah, although can I just, I also just wanted to add as well, thanks to Sheffield Voices and to Sheffield MenCap and to Healthwatch as well, who all work together on this piece of work. We funded both Sheffield Voices and Sheffield MenCap to undertake the work and to work with us to co-produce what that would look like, and I think that's shown in the wide variety of different and quite creative methods in which that's done. I also just wanted to highlight that, I mean, 178 responses we think is a good response rate, but within that as well, there are 109 individuals with a learning disability as well. So it's quite often in pieces of work like this, it can be made up of predominantly carers, because they kind of easier in terms of communication to do that. But I think that just shows the strength of our approach and the expertise and skills within those three organisations that we've worked with to actually really hear from individuals that have been directly impacted. So the next stage that we'd be moving on to is, I mean, we're actually meeting with NHS England, which is the first part of that. So we have particular statutory duties to uphold, and meeting with NHS England to inform them of our progress in the same way that we're here today is the first part of that. So that would be the next thing that we do. Following that, we'll be then, as Heather said, taking the feedback that we've got and trying to work out all the available and viable options that are available to us, and we'll be using the feedback that we've had. We also want to work with individuals with lived experience throughout that process as well, so they have a part to play in appraising those options. So we continue that lived experience throughout the process, not just kind of we've gathered some information and now we'll come up with the solutions. We very much want to continue working with those organisations to help us have the voice of those individuals in developing those. Once we've got those options, I think that's the point where we would want to come back to this committee to seek your viewpoint on whether you feel there is the need for further consultation with individuals, and obviously that will be based on how significant or substantial those proposals are in terms of the impact for those individuals. So we would very much look forward to continuing to have that conversation with you, and then we can decide at that point on what the next part of the process is, whether it's an implementation or whether it's a further consultation with individuals.
So I'll stop there because obviously we covered quite a lot in the last discussion, didn't we? So if I just open it up.
Thanks very much, Heather and Richard. Questions? I'll kick off while you're having a think. Hang on, let me just say which page I'm on here. Page 33 in our large report pack. There's something from the feedback that slightly unsettles me. First, I'll echo Richard's comments that the process undertaken by Sheffield Voices and MenCap and Healthwatch does appear to have been exceptionally good, especially in reaching so many actual service users and enabling them to give their feedback effectively. So this bullet point just troubles me slightly. Some people said they don't like out of authority or out of area placements as it's too far for family to travel. And we've discussed that before, we understand that. And it increases risk of abuse when no one is visiting. I'm just wondering where that kind of comment has come from, why risk of abuse is being raised.
Yeah, I think that's really part of that whole panorama exposés that have happened over a number of years. So started with Winterbourne View, which led to the Transforming Care programme. And that was about people being placed without scrutiny. I mentioned earlier that the safe and well checks have been put in place, and particularly recently, because the more recent one was at Walton Hall up in on the northeast of the country. So, and what I was saying about the care and treatment reviews, it's about us making sure that we pull together that multidisciplinary oversight, including local authority social workers working with the clinicians in the care trust to review people. So there are people in placements out of city, children and adults in residential or educational settings. And I think part of us looking at future options, if indeed we get to the point where we say we don't need Firs Hill in Sheffield, but we sometimes do need a hospital placement, we would have to have the most robust scrutiny that we can put in place to assure us of people's safety. Now, one of the issues that we've got at the moment, if I were to say to the Care Trust, can you travel 200 miles to see somebody? Not that we have anybody 200 miles away, but you know, their resources are limited. The whole point of what we're wanting to do is invest in community services, particularly putting that out of hours supporting overtime, evenings, weekends, and to actually have people within the community teams that are responsible for checking in on people's care, alongside the member of my team that I mentioned earlier, the nurse that we have working in the Integrated Care Board team. So I think it is a fear that everybody would have around a placement, but those fears exist in Sheffield too, around people's placements, and you know, that's about the quality control, the oversight, and the quality of the provider.
Okay, thanks. Mary, Councillor.
I suppose my question is about prevention, isn't it, really? How can we prevent people deteriorating? How can we prevent people experiencing a breakdown because of the stress that is there in the community, there within families, you know, and it's, again, goes back to a therapeutic relationship, therapeutic environment within the community with people. So I think that sort of sounds fundamental. But inevitably people do need a respite, they need a break, they need to get out of the situation so it can be reassessed. So I guess what do we put in place for that? And I remember many years back, and you'll probably remember it, Heather, when we talked about having a hotel. Do you remember that?
Yes, I do remember that.
Many years back?
Yes, I do.
That would be run by people with a learning disability, managed. Yeah. Everybody would have there'd be lots of jobs as well as somebody can go along. And it would be in Sheffield, it wouldn't be in Bridlington, it would be in Sheffield. There you go for, and I know that's not on the cards, but that would be nice. And maybe something like the unit at Lightwood, Chair, we went to see a few months ago as a kind of a respite place. But I think it's about prevention fundamentally, even though we know sometimes people do break down.
Yeah. colleagues, some of you do know and some don't know, but my sort of background many years ago now was learning disability as a clinician. I specialised in behaviour that challenges services. My experience from those days is if you can put wraparound support from local authority social workers with expertise, from clinicians within those specialist services, you can often prevent breakdown, you can often support a family or a provider that's struggling. When we have large numbers waiting for services or large numbers of referrals, that becomes a problem. So part of this proposal is trying to enhance those community services and enhance the offer. I think the other part that you just touched on is work that my local authority colleagues, Andrew and his team, are leading on around reviewing some of the provision in the city, looking at some of the things around respite. We are doing a piece of work across South Yorkshire on a step-down facility like you've just mentioned. I think you must have visited Blackwood, recently, the ex-Wainwright Crescent facility, which is really great that you went there, Councillor Lee. So we're doing a piece of work with our colleagues across South Yorkshire, looking at if we can develop something of that nature for people with learning disabilities in order to prevent an admission, because we are talking very small numbers. So to be able to do that just for standalone in one place is difficult. So we are doing that piece of work, and that's kind of underpinning this work that we're doing for Sheffield.
Lucy.
That's partly touched on what I was going to ask, actually. I was going to ask about that connection with the local authority and the work that's been taking place around the sort of working age framework, sort of things like respite, supported living and day opportunities, and whether or not the learning that came from that bit of work is being used to inform the thinking on what's needed, but also, like, on a really practical level, how you're kind of working out what health is going to do in that space, what social care can do to help people stay well, because they're both a really important part of the picture. So it was on that. And then there was just to say, was there a public question on this item as well? Are we going to take that at the end? I was just curious as to what that... Yeah. All right, thank you.
Thank you. My colleague Andrew Weewall's here from local authority, so I don't know whether it's appropriate for me to ask Andrew to comment on some of the things, but in terms of collaborative working, we have a commissioning manager that works in my team and works over across in the local authority, so tries to bring that learning, if you like, and make that connection between us. And then the Care Trust have got the Learning Disability Board that is looking at community services and how they would like to see community services develop, which Andrew and his colleagues and members of to attend. And I think we met earlier this week. Yeah.
Do you want to see?
That's right.
Thanks.
Do you want me to respond or add on to what's just been said? Yeah, I'm Andrew Weewall, Assistant Director, Adult Social Care in a service called Adult Future Options. One of the things I think, I do need to come back and answer your question at some point about where somebody was and where they are today from Thurshill, because I think it's a really, really good it's a good situation, so I would more than have to come back and talk about that. I think what we have found in the local authority is that there is this gap that needs to be addressed in using the providers that we pay for and we commission to have their knowledge base and their sort of respect and value base with ourselves and yourself in the right place, and we need to bring them closer to our working partnership approach. We've gone out recently for a tender for an enhanced framework, which is around short breaks, residential respite, supported living and day services, where those provisions they're not as they used to be. They're more progressive, they're outcome-based. We're expecting them to be a bigger part of the MDT, the multidisciplinary team, which supports people staying out of hospital, ensuring that we've got earlier intervention and understanding of crisis that might be coming down the line, so we're picking things up at the right time with family members and practitioners, health and social at the same time, and respecting their viewpoints as providers. That's clearly a difficult area where some of our failings of the past have led us to struggles in bringing people out of hospital into the most appropriate placements. That's a real challenge for us all. And I think one of the examples about the enhanced framework, bringing those people on board and how we commission is a really, really good response. We're not talking of hundreds of people, we're talking sometimes less than 5 or 10 people a year with traumatic, challenging aspects of their life that we need to address, and we should be able to deal with that. We have a present situation, if I give you one example, of a young woman who we have struggled to find emergency respite for and planned respite for. So challenging. We've now got to the point of being able to look at a local authority's establishment, a building that we are recommissioning, and we've got a provider on board with this, and we're going to be able to provide care for somebody with extremely challenging support and respite that's not had that respite for 3 years since coming out of children's services, and even then it was a struggle. So we have moved on, expressing that these are small numbers, but that the impact on every single person is absolutely quantified, but it's a big impact on the family, it's a big impact on us as provision and commission services, that we're not having the right places at the right time for the right issues to be dealt with. I think we certainly got there with some of the work that we're trying to do at the moment. So, thank you.
Thanks very much. I think as we're delving a little bit into this realm of what might be looking appropriate going forward, I know you're not there yet, Heather, with evaluating the first phase 1 engagement, but you know there's a lot of information that's come out of that already. So without jumping the gun, we have had a question from a member of the public whose son is a service user, and I think that it touches on the same thing, I think, really. So this is from somebody called Jeff South, who sent this question in but wasn't able to attend today. So he says, Firs Hill has always had good reports prior to this last one. It has always had long waiting lists for admissions from many areas outside Sheffield. Our son Andrew had 3 stays with excellent outcomes. It has never been intended to be a long stay hospital. Any cases of more than 6 months duration would be the result of a lack of suitable placements from care providers outside the hospital's remit, exacerbated by COVID restrictions and related staff shortages. We strongly believe that this hospital should be kept open to give people with learning disabilities who also suffer from severe mental health problems a compassionate and safe environment not available elsewhere or anywhere else. So I don't know whether have you seen a copy of the question, because I can pass that to you if you want to be able to.
Yeah, I haven't
see that.
I mean, I think it's interesting in terms of a snapshot in time, because respectfully, the gentleman refers to waiting lists from out of area. That hasn't been the case for a number of years. In fact, our out of area colleagues have made it quite clear they don't want to co-commission the service with us, because similar to ourselves, their numbers of people and the demand for the need for an admission has reduced as well as part of that Transforming Care programme. So it's not a person whose name I know to know when that person did use the service. But certainly, the circumstances have changed, and as we've heard, the kind of very minimal numbers of people that we've needed to admit over the last 2 to 3 years is kind of evidence of that. Whilst appreciating the feedback, though.
Okay, and I think just to pick up the gentleman's last comment about giving people with learning disabilities who also suffer from severe mental health problems a compassionate and safe environment, not available anywhere else. So I know you've already talked about what you're doing to provide something of equivalent value or better in another setting. So perhaps you can just reiterate in direct answer to that concern that there might not be a compassionate and safe environment anywhere else.
Yeah, so I think that is all part of the options we want to look at and what we need to put in place in the city. It's part of that enhancing the community services. It's this the step up, step down facility that I've talked about earlier. It's some of the things that Andrew's just outlined around enhanced frameworks of care and support. But for me as well, it is about those specialist clinical skills being available to support people and to support people in the community to do that prevention work that Councillor Lee talked about earlier.
Can I just add on to that? And it therefore answers one of the questions I was going to respond back to yourself, Councillor. It would be very difficult to say that that provision isn't sensitive and available elsewhere and compassionate. We've just recently had somebody who left Firs Hill a couple of years ago under quite difficult circumstances, and it's extremely difficult to find a suitable placement with a provider that can meet this person's needs. I won't go into the details, but there were an extraordinary number of complexities that were going on at any one time with this young man. And we found a placement in London, and they've done a remarkable job on this young person. Going back to some of the other questions that have been answered, we supported his family who were from Sheffield and didn't travel, didn't drive, etc. We supported them to stay in a hotel in London, very close to where this young person was staying. And we did that 2 or 3 times. We escorted them down. We supported them as a family unit, whose first language wasn't English as well, so it was quite difficult for everybody. The provider did a remarkable job. This young person is now, 3 months ago, beginning of January, moved back up to Sheffield, very close to where his family live, in a property that we purchased, or the NHS helped us to purchase. We put an enhanced framework provider in there who've done a great job. They've got staff members who've got the same language, first language as this young person. His support was extremely challenging, up to sort of 3 to 1 at any one time. That means that his behaviour was aggressive and his communications were extremely difficult, and it was a really, really challenging position to find anybody in. And he was still growing as a human being as well. So he did all of those things away from his family, nobody to support with the language that he could speak generally. We've now got him with those providers, a few miles away from where his family lives. He has one-to-one support and occasionally has 2-to-1 support, but not very often. His behaviours have calmed down dramatically. He's living a high-quality, decent life in a lovely place with family visiting 2 or 3 times a week. It's a remarkably successful ending. Well, it's a progression, not an ending. But it's progressed remarkably in the last 12 months. And unfortunately, it does take a long time to get those things into place and to make all of those things successful. We could have moved him elsewhere, and it may not have worked. The way we did it was extremely sensitive, compassionate, had this person at the centre of what we were trying to do. We purchased a commissioned provider, and we wanted 40% of the staff to be able to speak his first language. He has now started to speak English as well as his first language. So that's been a great success, I believe. What we didn't do, that doesn't happen by accident, and it does unfortunately take a great deal of time. But it may be one person, but it was one person out of probably 2 or 3 in that year that were extraordinarily difficult to place and to support. That doesn't take away from the thousands of other people that we support every single day. Less challenging and less complexities, but it can work, and it does work, and we have built upon that. So we've built upon that model, and we've, as I say, we've got short breaks available in Sheffield now that we didn't have 12 months ago. And so the lesson learned about community support has come through all of those things. It is about feedback, it is about communication, and it is about, for me in particular, it's about, I think Mary said it with, Councillor Mary Lee said it, we have to have the right values, we have to have the right leadership, and we have to be compassionate in what we try to do. There are no easy wins in working with people with learning disabilities. It's hard work at times, and sometimes it's not very rewarding. We're sometimes challenged on our outcomes, but I do believe that we are in a different place at the moment, and I think that's because of the work that we're doing with both the Trust and the ICB and that being successful in engaging with people in the community and that feedback and that response and that in consultation. And we've done a lot of work that's probably put the right environment where it needs to be at this moment. So thank you.
Councillor Lee?
I don't want to bring money into this, and I think that's absolutely a great story, and the things we should be absolutely going down that path when we need to, and you found a great place and it's successful, and we have to maintain that for that person. I just think when we think about the overall budget for social care and how much that must have cost, I just want to say, you know, this is why we're in such a difficult position financially, because we're doing the right thing by people and putting the right things in place, and it doesn't come cheap. It costs us a lot of money, which we need to be able to do and make sure everybody, including the family, we make it easy for people to get better, if you like, and improve. And I guess the other one I was going to say, that there's a lot of people out there, low profile, quiet, but suffering in silence, if you like, and we need to sort of ensure we get to grips with them as well and understand that they, you know, well, you know, Andrew, you've lived and breathed it for a long time, and I guess you get parents, and I know, who live a life of anxiety because they worry, don't they, what's going to happen to that person, my person, when I go, and I think that's an underlying stress within a family all the time, and it's continual.
Can I respond to that? I think Mary's absolutely right. There's a strong challenge here, and I think on the expense side of things, we've utilised monies that we didn't have, that weren't from Sheffield, they were from national NHS, which is still a spend of public money, but it was the right thing to do. Going to the point where there are thousands of people in Sheffield with lower care needs, and each one of those people and each one of those families, they have a life ambition. They have an ambition to be a successful individual or a supportive family that can do the job that they need to do, and look at us to support on occasions and not to be dependent upon us for everything that they need. That's our strong challenge, which I think we're getting where we need to be. We're looking at a named worker approach, which covers supporting people in all different positions, particularly carers. One of the successful things about carers at the moment is that we've just pulled together a small group of staff working for the council, working within our services, that are starting to look at carers a lot closer. And we're trying to run some clinics coming up in the next few months, Mary, where we've got carers who've got children in their 40s and 50s, because we have carers in their 70s and 80s, and we fully appreciate that. And we're trying to support them through the life developments of their son or daughter. And so it's not a crisis intervention at the end of the day. So we're working towards a plan of action, which is what we're trying to do today and where we're going to try and be over the next 5 to 10 years. And that approach with carers has been quite successful so far, and we'll enhance that in this next financial year. That's what we're trying to do. We're trying to deliver on ensuring that nothing becomes a shock to somebody and that they feel supported at all aspects of time. And starting point of this is our approach in transitions. We're working closer with children's services, where we're now having social workers from adult social care working with 16, 17-year-olds and working with those families about expectations and progression and development of their lives. So we're not just waiting till the end of the life, but we're trying to capture it early and then work with people as we go along. So thank you.
Thank you. I think we'll look to wrap this item up so that we've got plenty of time to hear from Emma. Was there any other questions?
Thanks, Chair. Thank you for the report. It's just a quick one. It's good that there is less demand for inpatient beds because of community work and working differently. I think that's really good news. And I was happy to hear in Andrew's previous answer the example of the support available for the family to visit in London. I thought that was really important. I just wanted to confirm that when we are thinking about options for inpatient beds, for that 1 or 2 beds that we probably do need provision for, that we are looking at potentially commissioning a facility that does have good transport links, because I know in the report it was specifically raised. People wanted facilities in Sheffield, came back quite clearly, and I think also separately, but I think related, was people wanted to be able to travel there. I think that's probably key. People want to be able to get there. and that we're looking at good public transport links as well, because like in Andrew's example, not everyone has access to a car, so that's quite important. And where that is a struggle, that there will be support for families to visit patients. Thank you.
Yeah, I think that's a really fundamental thing that we would have to put in place should we go down that option of needing something out of city. Because I think we need to put that wraparound support to families, and we need to help them, particularly those families that are older or have got other children to support in their families. So that has to be part of the offer. And when I mentioned needing to have an enhanced community service offer, that would be that there would be clinicians available sort of beyond just the Monday to Friday 9 to 5, and they would be in a better position to support families. I would want us to assist people to get to those placements and to make sure that they maintain the contact with the family. And I would want that to happen through the partnership work between local authority and the Care Trust and ourselves.
Just to add as well, I think any options that come out of this process, each one of them will have an equality impact assessment that's attached to them, and absolutely I would expect that to be a fundamental part of that, and not only recognised in that impact assessment, but then properly mitigated for where possible. So yeah, I completely agree. Thanks for raising.
Thank you.
Just going to add one little comment about the engagement carried out by the South Yorkshire Integrated Care Board itself. Just really, that is very low response rate. There's just 13 people. And to me, that compared with the response rate achieved by Sheffield Voices, MenCap and Healthwatch, really highlights the importance of identifying and employing the right partners for effective engagement. And public engagement, you know, and co-production, it's great to see, runs throughout the governance and strategic work of the integrated care system. So it's something of a watching brief really for this scrutiny committee and for the joint South Yorkshire scrutiny as well, to see how that is working out in practice. And I think this is a brilliant example and should be noted as a brilliant example of identifying and finding the right partners to help with that engagement, in comparison perhaps with the engagement that was carried out very swiftly before Christmas to inform the integrated care strategy, which received 500 responses from a population of 1.4 million people. So I think it's, you know, it's an obvious lesson that I'm sure you'd learned before it came to you, that, you know, to find the right partners to undertake that work.
Thank you. It's important to us. People with learning disability don't have an opportunity to give voice, and so we knew that we had to do that through third sector partners to really get that sort of reach into communities. And as Richard said, we're really grateful to those partners for helping us with this programme.
Yeah, and I think for me, it's there's always a strength in a multi-method approach, and you know that there is a place for doing more general, and the online survey was kind of put in there to get wider perspectives from people that may find that easier, but absolutely I think that the numbers borne out there show exactly why we wanted to do that, and yeah, and as you say, they were the perfect partners to do that with, but that doesn't come by accident either. That comes from the building of relationships with those communities and with those organisations, and certainly we've worked with both of those organisations through a number of recent projects, especially in Sheffield. So for the kind of the health centres and for COVID and flu vaccinations, things like that, they've been fundamental partners to help us along with that.
Thank you. So I think that brings us to the end of that item, and we'll just note that we'll send a little written summary of your answers to Mr. South's question, along with a link to the webcast so he can watch back that little discussion. So members, we're asked to note the update in this paper on progress on engagement and receive a further paper on options for future delivery of the service as soon as possible after the election period is complete. And have we got a proposed date? that. I think you were asking for May,
So
but
that's much appreciated. You've given me a date in May.
I think it's likely to be the 1st of June at this stage, but the diary's obviously being worked out at the moment. So certainly it's a priority
Thank you
to
very
get that in
much.
May, end of May or beginning of June.
Thank you, I really appreciate
Are we
it.
agreed, members, to accept those? Thank you. Thanks ever so much for your time. Okay, so we're on to item 9, NHS commissioning in place, to discuss the Sheffield arrangements for commissioning. And we have Emma Latimer joining us. Thanks for waiting so patiently, Emma, to present this item. So, and I think you've got a PowerPoint presentation for us. Have we got that queued up? Brilliant. Okay.
Thank you very much.
Thanks, Emma.
Good morning, everybody. So I'm Emma Latimer. I'm the Place Director in Sheffield. I sit on the South Yorkshire Integrated Care Board. I've been in situ since the 1st of July. I've worked in the NHS for 33 years. I was a Chief Officer of 3 clinical commissioning groups in the Humber area before I came here. So yeah, it's been an interesting journey so far. So this morning I'm here to talk to you about 2 things. One is the Integrated Care Partnership, and the second is the place arrangements that I've put in place since I've been here, about how we start to work together moving forward. So I think the slides are there. Thank you, Deborah, for that. So the first thing I was going to touch on is the Integrated Care Partnership. So ICB's took over the functions of CCGs, and we've been kind of guided through this process by the Department of Health and Social Care. So when we came into being on the 1st of July, one of the things we had to do was to create an Integrated Care Partnership. And so in South Yorkshire, we have the Mayor who chairs that. So he chairs it on behalf of the 4 places. There are 4 places, as you know, in South Yorkshire. And he convened a group, I think it was probably end of July, to start working through this. I noted your points, Councillor Milton, about engagement. I think that's a really crucial point. So the idea was that we'd have this document in place by the end of December, and that we'd launch it before the end of March or beginning of April this year. So we didn't really have an awful lot of time. So I would say this is very much an interim position. It's certainly not a finished article. You can never stop listening or learning. And so I think that's something that I wanted to point out from the start. I think this has been done pretty quickly. I don't think we've engaged in the way that we need to. And I don't think this should just be a kind of, a finished article in any way. So the working vision, it says on the top, is everyone in our diverse communities lives a healthy, happy life for longer. There are 4 shared outcomes: best start in life for children and young people, living healthier and longer lives, and improved well-being for those in greatest need, safe, strong and vibrant communities, and people with the skills and resources they have to thrive. So again, I won't read it sort of line by line, but you can see what we're trying to do. And I guess the sort of advent of ICSs, I think for me, has been something that, if the policy is allowed to work, it will be really helpful, because most people, it's the wider determinants of health that really impacts on their health and well-being. So actually, if we don't start working together in a very different way alongside our communities and start to truly empower our communities, we're always going to end up providing hospital and acute care, because we're not actually addressing the areas of need that people actually have. So I think the actual ICS policy is a good one, but it's how we apply it, and how we actually start to work alongside other partners in true partnership, as opposed to I think that the health system is very command and control top down, but actually we need to build from the bottom up and really get alongside our communities. So there's some bold ambitions there and some joint commitments. So just moving on to the next slide, and this is just touches on your point around the engagement. So we'd already got a lot of engagement in place. We'd had 284 reports from what we'd heard. So we used some of this to inform the bold ambitions and the strategies. We did some work on our website. We asked people to comment, but as you said, I wouldn't sit here and say that was sufficient. I think it's a point in time, and we need to learn from that. So I think this is going to be a continual process. If you just want to move to the next slide, please. Thank you. So the national guidance is there. What we're expected to include was stuff around shared outcomes, quality improvement, the joint working Section 75 arrangements we have, data and information sharing. And I think, as I said, we tried to build on the work we already had. We obviously have to pay due regard to all health and wellbeing strategies. That's really important, and we've done that. And obviously, building on the work we'd already done around integration, although I know we probably haven't gone far, we absolutely haven't gone far enough in terms of making sure that we incorporate everything within that document. So it's going to be published tomorrow. I assume that you've already, I know the Health and Wellbeing Board have already seen the document. I'm hoping that you have. There'll be plenty of publications tomorrow around this. And again, the Mayor's launching that tomorrow. So in terms of alignment of strategies, you've got, in the ICB, we have the NHS sort of ICB board, which does the kind of old traditional NHS commissioning. We've got the South Yorkshire Integrated Care Partnership, which is chaired by Oliver. And again, that's about wider partners coming together, much beyond health. And then we've got obviously the Sheffield City Partnership, which is the goals work that's being developed as we speak. We've got the Sheffield Health and Wellbeing Board, and we've just got this newly established Sheffield Health and Care Partnership, which I'll come on to. So I don't know whether I'll just pause there, because as I say, I wasn't trying to kind of go through the whole document, but really interested in your feedback on part one of this before I go into the governance arrangements around place.
I think just carry on, Emma.
Okay.
Thank you.
Yeah, thank you. So when I arrived in Sheffield, I think it's fair to say that we were probably slightly behind other places. So place working that had gone on in the other three areas seems to be much more collaborative, I'd say. So we had very much a kind of commissioning CCG and a local authority forum, and then we had a forum that had the providers of healthcare on it, and they were operating in two different spaces. We talked about health inequalities a lot, but I couldn't really see it. I couldn't really see how we were addressing that as a partnership. So I came in, and what I'd say is that these partnership arrangements have been co-produced. So I didn't write them in a dark room. I co-produced all of them with people, because this isn't about ICB doing to people. This is about a genuine partnership for Sheffield. You know, this isn't a command and control health thing. It has to be a genuine partnership for us to be able to make impact for the people that we serve. So I think that was key for me as we started. So in terms of what we've done is I've combined the old kind of joint commissioning committee as was and the Sheffield Health and Care Partnership, which was the provider elements, together. So we've got everybody in the same room. I think that's really important. We've obviously got four outcomes as an ICB, which is around better health and wellbeing for our population, reducing health inequalities, driving forward sustainability and better quality of health for our population. But again, you know, words and governance structures are all very well, but actually, how do we hold ourselves jointly accountable for delivery of some of this? I also inherited numerous strategies that were sort of pages long, but what I couldn't see is, you know, what did we actually delivered? What were our key priorities, and how did we really focus and put our joint effort and energy behind those? So that was this kind of purpose. We've then got a framework around, you know, not just about how we make decisions, but how do we start to jointly develop our priorities? And I'll come on to that probably later on, if that's okay. If we just move on to kind of the vision and purpose. So the vision and purpose was already here, so I inherited that, which is for our health and care services to be integrated, joined up and seamless, to reduce and remove inequalities in health outcomes and access to support by playing a full role as an anchoring organisation in our city, and to do all this in a way that involves people, their experience in our communities at the centre of this work, and that is still very much our ambition. We've got three strategic aims for our health and care service to be integrated, joined up and seamless, to equalise outcomes and reduce inequality, and to involve people, experience and communities at the centre of our work. So actually getting people with lived experience and actually allowing them space and opportunity to purposefully influence and help co-design some of the things that we do. And then we've got some sort of framework principles which are there as well. And I think one of the beauties of our new committee is that we do have elected members as part of that. And I feel, again, having them alongside us really gives us that democratic legitimacy in the right place. And so I do think it strengthens that local decision-making process. And I feel hugely privileged to have them around the table, because I do think it kind of really grounds us in place, and I think place is so important in healthcare moving forward. So just moving on, this is the lovely slide. We love these slides in the NHS, don't we? These massive organograms. So what you'll see at the sort of left-hand side, we've got a Sheffield Chairs group. So when I arrived, everybody was in the same place. So when we have some difficulties, as we do, trying to convene, because I think in the ICB our job is a convener, if the chairs and the chief execs and everybody else meets at the same time at the same place, how then do I help unlock some of the issues and the difficulties and barriers that we face? So we have a chairs group at the moment which is chaired by Annette Laban, who is the chair of Sheffield Teaching Hospitals Trust. It has all the provider chairs on it, also has VAS on it, and it has a place for the local authority as well. So again, that's just about, I suppose, them holding me to account as the place director to ensure that we're working together, and also to help me unblock any challenges or barriers that we may have. We've then got the Sheffield Health and Wellbeing Board, and again, I think that is the front-facing part of this, you know, making sure that we are, it's obviously a subcommittee of the local authority, but making sure we are absolutely being transparent about what we are doing. We've then got the South Yorkshire Integrated Care Board, which, as I said, replaced the old CCGs in function, and the South Yorkshire Integrated Care Partnership, which I've talked about. So underneath that, we've now got the Sheffield Health and Care Partnership Board, which incorporates the old health and care partnership arrangements, which were predominantly the providers meeting, the ICB duties, so there are things as an ICB that we need to bring to that committee, and the old Section 75 arrangements, which were the arrangements around joint commissioning between the CCG and the local authority. That meeting is held in public. It meets every 2 months, and currently I chair it. And again, I didn't say I wanted to chair it. Again, every stage of the way I've offered a really inclusive approach to how we design these arrangements. And underneath that, we've got 2 committees currently. One is Sheffield Transformation, the other is Oversight. The reason for that is, again, when I was attending meetings early on, I was in rooms where we just kept talking about a problem. We've got too many people waiting to be discharged. We've got too many people waiting for an assessment, a neurodiversity assessment. But we just kept sort of sitting in rooms talking about the problem. We didn't seem to have any headroom to think about what we could do differently. So I've tried to kind of separate what I'd call business as usual and transformation into 2 areas, so we get a bit of headspace to think about the art of the possible, because everyone starts with, we haven't got the money, but actually if that's all you start with, we're never going to do anything different. So actually we need to start from a different premises. What is the art of the possible? What are people with lived experience telling us about what matters to them, and then what do we do next, rather than whose money is it, whose fault is it? That's not relevant in terms of the people that we serve deserve better in my head. So that's the way I've tried to structure it. And then we've got a number of groups down the right-hand side which are kind of doing this sort of business as usual and some of the transformation. I would draw your attention to the Community Development Inclusion Group. So this is a new group, and this is a group that it will be co-designed by our communities. It will be co-chaired by somebody in our community, not necessarily an infrastructure organisation, the VCSE. A grassroots leader is what I'm looking for in this space, because again, if we're really truly going to empower people, we need to, if they want to take the power, we need to give it to them. And I think there's a huge power imbalance between statutory agencies and communities and voluntary sector, and we need to see that equalised as we move forward. And so really interested in that work. That will focus on health inequality and health inclusion. So ensuring that the most vulnerable people in our community, asylum seekers, sex workers, homeless people, absolutely get priority. They are the most vulnerable people when it comes to receiving healthcare, and that cannot carry on. So again, I want to be really specific about building on the work that we've already done, but really making sure that group is truly represented. And then we'll be focusing on community development. So looking at the most deprived places in Sheffield, working with our local area committees, working with the police, working with schools about really getting into what matters to people and what would make a difference to their lives, and how then can we work differently together, because often it's not medical intervention that's needed, but we give them medical interventions because that's what we're used to doing, rather than asking people what would make a difference to your life, and how can we as agencies support you and work with you. and allow you really to inform what we're doing. So that's the kind of meat of this really in terms of governance. We will be reviewing it in 6 months because again, a piece of paper with a load of boxes on isn't enough. It's about actually, are we doing what we said we were going to do? Can we actually hold ourselves to account to the public, to yourselves, in terms of what we're supposed to be doing? There's more information, and again, happy to share these slides. And sometimes I think slides are helpful, and other times reports are helpful. But I just thought, just to introduce you to the concept, the slides would be a useful start. So as I said, we are looking at Section 75, Health and Care Place Partnership priorities, and what we need to do from the ICB perspective. And the slides just go through. I'm sorry, there's an awful lot of detail on here. So I'll probably just take you to the membership, if that's okay, the Sheffield Partnership Board membership. Again, it might be a bit small, but you can see when we get to it, there's probably too many people on this board from the ICB. I think we'll review that as time goes on. But we have got the Director of Public Health, we've got your Chief Executive, the DAS, the DCS, we've got all the Chief Execs of the providers, and we've got Health Watch, and so there's a huge range of people in that space. We are really trying to collectively do something and own it jointly. So that's the current structure. I've talked about the Sheffield Transformation Committee in terms of actually we also work in silos a lot. So people were sort of looking at their own bit of the world, but actually how do we have a read across what are the benefits we're trying to realise as a health and care system. So the Transformation Committee is really trying to draw that together rather than people, because people make decisions and don't think about the impact, not only on our communities, but actually on each of the organisations. So we often make decisions that impact on one another. And again, this is about trying to draw that together. In terms of the Oversight Committee, there was without a doubt a set of risks as leaders that we've identified in the city that need to really be tackled. So again, the role of the Oversight Committee is, rather than the Place team or the ICB having a conversation in a silo with one organisation, you often find, the issues are multi-agency. And so this is about, again, trying to share information intelligence and work collectively to solve some of our biggest problems. So that is very much around, what's happening performance-wise, where do we need to focus our areas, and where do we perhaps need to ask the Transformation Committee to take a slightly different role on some of the areas that we look after. The delivery groups I talked about, they're chaired either by a clinician and or an executive. As I say, the community development one is very different, and I want that to kind of grow a bit more organically. And there's just a slide at the end which talks about the delivery group arrangements. The final slide is around priority setting. So we've actually had an OD session, organisational development session, because again, what I'm trying to overlay here is not just an approach to priority setting, but also how do we behave. So the compassionate leadership piece, I think, is really important in terms of we've got to get out of blame, we've got to get out of it's that if only they did this. We need to have collective inclusive leadership. That we owe that to the people that we serve. And so it's not just about what we're going to do, it's actually how we're going to do it and how we're going to behave to one another. And so we're now just working up the priorities, and again, they're all linked to the Health and Wellbeing Board, the Joint Strategic Needs Assessment. It's not new stuff, but we need to move on it. I think what happens in the NHS is, and at 33 years, I think I've been through 9 or 10 organisational changes. So we move the deck chairs around on the NHS Titanic, as I call it, and then somebody new comes in, everything seems to stop, we get into inertia, we don't move anything on. What's really struck me as I've got older is wherever you go, the JSNA says the same things. People, we're not getting better, we're not improving people's lives. The cost of living crisis doesn't help that. But what we need to think about is what currency do we need to plan? And local authorities obviously are place shapers and probably do this much better than us. But actually, what matters to people is usually the street they live in, that very small community around them. But what we keep doing is coming in and changing the way we plan and commission services. And we have a bit of inertia and a bit more inertia, but the problems stay the same. And the workforce is largely the same. So if we can start to think about a unit of currency that really matters and makes sense to people that live here, then that's where we should be focusing our effort and energy, and it should be bottom up rather than another NHS construct, we're going to do this to you. we're going to do that to you. And we wonder why we never make the impact that we really need. So we are, as I say, it's not perfect, and it's certainly, you know, we can't change the world tomorrow, but I think it's about really getting us to a place that whatever NHS restructure may land in the next 5 years, the plans will still carry on because they're built around people and communities and the staff that work here. So we are looking at that at the moment, and obviously once that has been agreed as the kind of key priorities, I'll come back and share that in terms of what that will mean to people. So that was just really a sort of canter through what we're doing, but really happy to take questions. Thank you for listening.
Thanks very much, Emma. That's a lot of information.
Yeah, there is. That's NHS for you.
Great. I did jot down a question somewhere myself. I'm just going to try and get back to it. I've lost it now because I cleverly did it electronically. There we go. I was just going to take you back to your slide that had the 4 blue boxes and strategic and operational bodies, and just if you could just explain for people who have no knowledge about this, the different roles of those 3 Sheffield-based boards. So you've got the Sheffield City Partnership, Sheffield Health and Wellbeing Board, Sheffield Health and Care Partnership. Just if you can try and verbalise just a little bit more about why have we got these 3 different entities? How do they collaborate? Who reports to whom? You know, who's got the oversight?
Yeah, the Sheffield City Partnership is actually led by the local authority. That's the City Goals work, and I sit on that as a representative of health. So my view is that we can't, if we're building city goals, then health and inclusive growth has to be part of that. It can't just be about economic growth. We need to think about that. So that is current. So I currently sit on that. It's a local authority-led governance framework. The Sheffield Health and Wellbeing Board obviously is led again by yourself, a subcommittee of the local authority, and its vice chair is my medical director. We sit on that as a partner. And that has to write health and wellbeing board strategy, and again it's not done in isolation. Obviously Greg does lots of work, Greg fell around you know, smoking cessation, all those things, really trying to I suppose it's not just about public health, but some of the wider determinants of health around housing and things like that. So again, that is a local authority committee that we are a member of. The Sheffield Health and Care Partnership is a ICB subcommittee. So the CCG was a statutory body. That the Place Committee is no longer statutory because the statutory element of it goes to the Integrated Care Board at South Yorkshire. The way that the Integrated Care Board works currently is that it has 4 executive directors and the Sheffield one, and through me, I get delegation of resource into the Place Committee. So as an individual director, I get the budget resource into Place through me as a delegated officer that sits on that board. So that's how those work at the moment. And that's why I report into the Integrated Care Board. The Integrated Care Partnership is the partnership element of the... So the ICB is held to account by the South Yorkshire Integrated Care Partnership for delivery of the strategy that I alluded to early on. So we love making it complicated, but I suppose what I'm trying to do very much at the partnership level is ensure that, you know, that what we do is docks into everything else. It's not something new and different, but we need to be able to demonstrate delivery and that things are starting to move in the right direction. Because, you know, we have got limited resource, but again, I think if we were to integrate more services, we would see some more efficiency, and that would impact on frontline services. So there are lots of opportunities, I think, to do better in this space, and that's really the kind of job of the Health and Care Partnership. So is that okay? Is that people okay with that? As I say, I know it's we love 3-letter acronyms in the NHS.
Thank you. Can I just ask them, this is just a really open-ended question, what benefits have you seen so far from this integrated structure? which obviously is still in its infancy, but what benefits have you seen so far for Sheffield, and for have you seen benefits coming out of things being seen more on a regional footing?
I think if we just took the medical effect for discharge issue, we have been a massive outlier. So the number of people waiting in hospital beds who should be in their own homes, we've seen a big reduction in that since January, because I think we're all pulling in the right direction now. So some of these issues that, we have got significant pressure in our health system, as you know, in primary care, in every aspect of care at the moment. And I think, there's some duplication. There has been quite a bit of defensiveness. People are really tired after COVID. We've got a workforce that, has really worked hard. So I think what I'd say is, we're starting to make a difference in the way we work together to try and, I suppose, make life better for our population. But I still think, we're a way off yet. As I said, a governance framework is one thing, but it's how we start to deploy that, and how we really do listen to the views of our workforce and our communities, and how we start to shape things differently, because I think we've got a long way to go still in that space, being really honest.
Okay, thank you. I'm going to probably keep asking that question as time goes on.
It's really
because I think, integrated care, it actually looks, it really looks like a good way to work to me, but at the same time you can see so many pitfalls in how it could fail to work because of the complex structures that you've outlined to us.
Yeah.
So I'd be really interested to see how we start to feel the benefits in Sheffield, as well as when patients start to feel that benefit of the co-working across the region and a more coherent strategy.
And I think when I talked about the currency of planning, I think it has to be about consistency, not more complexity. We love layering things up, and I think one of the beauties of being South Yorkshire is that we can learn from Barnsley. Barnsley doing some great stuff on this. Actually, we don't tend to learn from each other, so I think there's an opportunity. But my view is if we really plan from the bottom up, and reduce the complexity, but keep consistency of planning and actually what matters to people, that's the only way I think we'll really make a difference, because integration is really hard to do. What's going to be different on Monday morning for people? And actually, it's not going to be done by managers. Every exchange that a patient or a member of the public has is usually with somebody, who works in the care sector or a clinician. They're the people making the decisions every day, committing the NHS resource. And actually, if they don't believe what the benefits are of integration, then again, we're not going to address it just by introducing a hugely complex governance structure.
I've got Mary and then Martin.
Thanks. There was a lot of information, and I haven't got my head around it. But okay. I can see where you're trying to. I think there's some important things you've said. You've talked about health inequalities, and it's the health service obviously has got a massive part to play, but so has a lot of other people. And I guess the health service need to, understand what other people's responsibilities are. 25% of our children are not in school at any one time.
Yeah.
What does that say about future earning potential for those kids?
Yeah.
Development of skills to increase their earning potential, and therefore taking more care of their health, because we know that it happens. You talked about things on the street are more important to people, and I think that's right. And I guess what services will be then devolved down to the community, what health services, physiotherapy, specialist services, because if they're in the community, I guess people will take more note of what's there and what's available to them, rather than somewhere over there in a big hospital, which they don't understand, really. And there's loads of questions, it's a discussion really, not a question and answer session, this, isn't it? And
absolutely. I've been in contact with the Chamber of Commerce. I've had some discussions with people around apprenticeships as well, because we need to be ruthless around this. This isn't just about health. As you say, somebody having a job, a meaningful job, is the best thing. In terms of health inequalities, it just makes such a difference. I always say that talented is evenly distributed, but opportunity is not, and that's not okay. And actually, we have a massive role to play in the health service around that as an anchor institution. We need to ensure that, you know, I look around the board table in the Integrated Care Board, it doesn't represent the community we serve. You know, I'd love, in 10 years' time, it'd be great if somebody, there would be a journey for somebody who then sits who's making decisions on behalf of the place that they grew up and lived in. That's the kind of place I want Sheffield to be, and I want to kind of play a part in that. But you're absolutely right. We've got to stop, you know, the hospital for lots of people, it's just, you know, it's the end, isn't it, rather than the beginning. So some of the work that we're starting to look at is around the northeast of Sheffield, and the local authorities did some great work and insights on that. So again, we're building on that, not just starting again. But rather than trying to look at the whole of Sheffield, because some, as you all know, some parts are more affluent than others, actually, where do we need to start to target the resource? So if we've got X million to put into a place, do we put that into the most department and then start to build on what have we learnt and how can we start doing things differently? Had lots of conversations with the voluntary sector. My view is that we shouldn't keep giving bits of money, you know, here and there. There should be a sizable chunk of the place budget that is recurrent for the VCSE, because I don't say to the hospital chief execs, any of them, I might give you some money next year, but we do to the local authority, to the voluntary sector. Again, we've got to really build confidence in that sector. It's a vibrant sector that does so much that's not even measured. A lot of the work that the VCSE do just is code with demand that's not even measured. What if it wasn't for them? I don't know sometimes how some of our services would cope. So I think we need to see the VCSE as an equal partner, but also our communities in empowering, supporting them as well. And again, you know, Greg, I'm going to talk to Greg and others. This isn't something it's not a lone thing, obviously. Lucy's here as well. You know, there's lots of people who are involved in this work in terms of where we're trying to go. But you're right, you know, looked after children. There's loads of issues that we need to kind of focus on. How do we really support families? You know, when, you know, there's different people going in. Health actually is a very small part of the children and young people's world, but you know, we need to work together and differently to prevent people who do need health, who do need our services, to get it quickly, and not to be on waiting lists for years. That really, again, is not acceptable and impacts on their life chances. So we need to really prioritise where we put our resource, I think, moving forward. But, you know, more than happy to come and talk to you about any specific aspect, because I know there's a lot of information that I gave this morning.
I guess some of our communities don't demand as much as other communities, and I think that is a key part of improving people's lives, ensuring that they can demand as many services as, you know, so it's equitable across the city. And we need to build people's confidence up to do that, and that's up to politicians as much as anybody.
Yeah, thank you.
Martin.
Thanks, Chair. I'm just wondering, looking at the governance structures, if local healthcare professionals are as involved in the ICB governance as they were in the CCG. I'm just thinking of the role that GPs used to have, and we used to have a GP as CCG chair in particular.
So in Sheffield, the CCG governance disappeared, but I still have 6 clinical directors, as well as Zach Whitmurray, who's our medical director. So I've still got quite a lot of clinical leadership. So in the delivery groups I talked about, there's a GP in each of those leading or part of that. So you're absolutely right. And one of the other things I've just done is commission a piece of work across South Yorkshire, actually, for clinicians to join virtually every 2 weeks around a lunchtime. They're all recorded to start to work through what is an ICB, what does it mean, how can people get involved? Because, as I said, just to think that a new structure and a new set of acronyms is going to make a difference if you haven't got the people who are doing the job involved is just not acceptable. So again, I think CCGs, and I was obviously Chief Exec of 3, did some brilliant work, because when we were making decisions, I had the clinicians in the room saying, well, that's never going to work. And I thought, oh yeah, because obviously they're the people that see the pain. And we can't lose that. You can't do, you know, there needs to be a blend of people involved in decision making, but it needs to be proportionate. And as I say, the power seems to be in the wrong place a lot of the time, and we don't get the best outcome. So, you know, so GPs are still very much involved in our work here, which is good. And they are, you know, we are trying to get much more clinical engagement in what we do, because it's clinicians that have the ideas. We're there to convene, enable, support, and help, I think, in my team.
you might not be able to answer this. I remember sitting in a lecture theatre in 2010 listening to a talk by Sir Gordon Duff, who said in the next 10 years, data is going to be key. And one of the projects that he was hoping to get off the ground, and never did because the funding wasn't there, was to map well-being, infections, conditions across the whole of Sheffield. So you could go to a street and see on that street what illnesses, conditions were affecting that particular street. And then as a result of that data, look at how you could target services in that area, but then also improve the health and well-being in that area. And that struck me as a really good way in terms of mapping out health conditions across Sheffield and how then we might target, and how we might then put prevention strategies into that. I suppose you might not be able to answer this, but to what extent are we using the data that we are collecting on a day-to-day basis and extrapolating back how then we might use that data then to target services?
We've got something now called population health management, which does that, which basically you can start to drill down by general practice, data on your patients. The problem with the NHS is we analyse rather than implement, and that's so we know we have lots of information, but if we're I would say if you're a business, you'd be using it in a different way, and so we need to be much more savvy about that. But we also need to give the clinicians more time, because they're constantly dealing with what's happening on the front line. But actually, when you start to work, some of our GPs, some of our primary care networks have done some really, really good work using their population health management data to look at how do we start to work with people who are diabetic, and rather than just giving them medication, they've got walking, they've got all sorts of things, because they know their population and they're putting interventions in that are very different. The problem is consistency. People don't use it consistently. Some people have got more time, others are more interested in it. It's not, as I say, if you're running a business, it would all that stuff would be really important. And I think people do use it, but not to the, not in terms of the way we should be. And as I say, the JSNA is a great example, isn't it, of telling us all the things, but we never seem to move it on, because, and as I say, when you overlay things like the cost of living, that's bound to have an impact on some of that. But you're right, we need to be much more sort of intelligence-led as an NHS, and I think we're getting better, but we need to do a lot more. But there's lots of stuff around digital and I guess artificial intelligence, all these other things that are coming that we're looking at. But again, it's as you all know, the NHS is hugely complex and it's fragmented at times, and it's just about how do we make sure we use that data. And also, some of the work that we started to commission is actually saying to some of our community groups, we don't have the answers. So actually we'll commission you to work with your community to come and tell us what matters. So again, I think we've got to think about, how do we engage some of our, we call them hard to reach, but I think they're easy to ignore sections of our community and work with them. But it's a really, really valid point, and one that we need to keep at the forefront of mind. I'd love to walk into my office and see a map of Sheffield and where everything was and overlaid against the needs, in terms of how do we start to match resource to demand, and what we could do differently, and where the opportunities are for transformation. So I think it's something that's constantly on our minds, and we'll need to get better. I think ICS is, again, we're all about defining, and improving population health. So we need to be using that data to drive the decision-making process, because clinicians do quite a lot, particularly in hospital, where they're looking at patients and the data in front of them. But from a planning perspective, I think we need to use it much more in conjunction with the local authority and other places. The police, we follow each other around into people's homes. So we need to get better at what we do. Thank you.
Thanks. We're nearly at the end of our time, so are there any last-minute questions on that? I've got one little one, which is just it's a comment that a question that I asked earlier this week at the joint South Yorkshire and Bassett Law Scrutiny Board about health inequalities funding that I believe was made available to the ICB and how that's been used Are you, do you know how that's been deployed? I mean,
Yeah.
it came to my attention because there was a comment that West Yorkshire have fully utilised theirs and deployed it out in actually, you know, how did you define it? We can analyse, but we're not implementing.
Yeah.
I think West Yorkshire have done quite well at implementing. Wondered what we've done with our money.
So I think we've spent about 3.5 million actually in Sheffield. Things like food banks I mean, I've got a full list of all of the money we spent last year before I arrived, so I'm happy to share that with you. But we have spent it on quite a lot of different initiatives. But what we weren't very good at is the public narrative around that. So it was kind of done in a bit of a piecemeal way. But this year, we're writing a proposal about how we use our new element, and it is ring fenced to us. So we've got about 2.4 million. We've got to spend some of that on. We're spending some of that on quit services, which is a service that's delivered in hospitals. So when people are recovering, it's about how do we try and stop people to stop smoking, because actually, as you know, that's one of the biggest issues we have around health. But then the other element, we'll be working through the partnership board in terms of these are the principles. We've got some thoughts around, as I say, trying to put it in the most deprived part of Sheffield, because if we try and spread it so thinly, we're not really going to see some benefits. But the idea is if we can start to learn and build some success, then, and we'll start to see a reduced demand in some of our, you know, our more acute areas, then we can start to build on that approach. But it will be really transparent and visible, and the fact that our board meets in public, I think, is a really good thing. You know, we should be meeting in public. We should be having discussions openly, honestly, about what we're doing with taxpayers' resource.
Mary?
It would be really good if we could understand, you know, have that list of where you've
happy
used
to
that
share
money.
that. I've got a list. We did it because obviously people have been asking where's that money gone, and as I say, some of it was spent even before I arrived, but we have got a record of that, and I'm happy to share that with you all in detail. And hopefully moving forward we'll have a much more I suppose partnership and open approach about what we're doing, and we should be really transparent about that. I think some of it, to be fair, has just been kind of lost in translation from one new system to another, but we should be sharing that information, and I'm happy to do that.
Obviously, you've talked about deprived areas of Sheffield needing more resource. I think that's really important. But how have you come to decide to give grants or money to which organisations? Just how you've come to those decisions. That would be, if you could give us a summary of that, that would be really good. I don't want massive documents about.
I mean, I think in the past a lot of it has been, say it's been a pretty piecemeal approach. If somebody's come forward, or it has been a bit like that. I would be honest about that. We've tried to do stuff around the cost of living, and again working with the local authority on what we could do to support the cost of living. So I don't think it's been a kind of well thought through approach. But we have spent money in areas. But moving forward, we need to be really clear about how we make decisions. Who's involved in that process. Take it to the partnership board so that everyone has equal voice around that. So I'd say we'd spent money. It probably hasn't been done in a very structured manner, but we need to be really upfront about the principles in which we're going to operate moving forward.
You mentioned Barnsley having a good model. It would be good to have just a bit of a summary about that. You don't have to answer that
for medically fit for discharge. They've been doing some really good work, and they take. I think they've shown about 17 other systems round. So I suppose when you've got good stuff on your doorstep, I think we don't always appreciate that or learn. And that's the beauty of being in a South Yorkshire integrated care board, because at least we can learn from each other, and we're hearing what works well in one part of South Yorkshire. So there has to be benefit in that, I think, for us.
But are colleagues happy just to extend the meeting by a short time, just to finish off with our final questions? And we've got a couple of items just left very quickly on the agenda. Are we all right for another 10 minutes? Thank you.
Sorry, Chair, I'll just be super quick. I just wanted to thank you for some of your comments, Emma, and agree with Councillor Mary Lee's comments on allocating funding to the most deprived areas in Sheffield. I think that's really important when we're talking about addressing health inequalities. And I think sometimes in the past what we've seen from the CCG and the NHS is more of an equality of funding, where funding split equally rather than funding targeting areas that need it more. So I just wanted to say from so you get a feel from the committee, from different kind of party groups. So I fully support that move towards funding the most deprived parts of Sheffield to address health inequalities.
Thank you, because the actual health funding formula, the Carhill formula as it's called, doesn't always recognise the inequality. So if you go into a school, obviously school, you'll know the pupil premium really does recognise inequality. I don't think health does in the same way. So I think it's our job to do, you know, as a convener, as a you know, as a sort of planner, to try and help some of that rather than just distribute it equally. And you know, there are practices who are really struggling because they live, you know, they are in really deprived parts, you know, where people. You know, there's a lot of different languages being spoken, and you know, it takes a lot of time to work through those problems for those people, individuals. We don't want to shortchange anybody in the city. So, I think having your support on some of this is really, really helpful. And the local area committee, I think structure, we just need to think about how that works alongside us. So we're doing it in true partnership and making, you know, better use of the Sheffield pound, because that's really important, I think.
Okay, colleagues. Thanks ever so much, Emma. It's been incredibly informative, actually. I'm really glad we've had this discussion today because, you know, that we've known bits and bobs about how everything's coming together since the integrated care system came about. And I feel like I've pieced a lot more together today, so thank you for that. And we'll probably want more discussions with you on a similar level in the near future, because I think it's really key to hear how things are panning out. If we could get that little report back on how that inequalities funding has been allocated, that would be brilliant.
Yeah, I'm happy to share that, and you know, either come back and talk through it or send it to you know, whatever.
I think if you send it in a written form, and then if members feel we want time to discuss that at a future meeting, whoever's on the committee next year, that could be picked up, couldn't it?
I just say thank you for your time. You know, I think it's hugely important that I establish a good and open relationship with this committee. It really helps me as well. So, you know, I'm happy to be challenged on anything, and really want to make sure we've got the best health and care services in Sheffield. That's why I joined. So, thank you so much for your support today and your comments.
Thanks ever so much. I don't think there's any formal noting of Emma's report. It was really on an informal basis that we asked her to come and discuss with us today. So I think that's business done. Thank you, Emma. See you again soon, hope. So, members, we've got just the item 10, which has been deferred because of illness, which is the maternity improvement update that we'd asked for. So that will be included, hopefully, in the first meeting, probably, of the next year. And then the quality accounts item, which, Deborah, can I ask you to explain that one? Thanks.
Thanks, Chair. We put this on the agenda because it was in the past what we've had is a situation where quality accounts come through during the election period. So by the time that the first meetings of scrutiny were convened, which would be around July time, we were missing the deadline basically for quality accounts. With us being under a committee system now, we were advised by legal that we would need to formally delegate responsibility to an officer in consultation with the chair to approve those during that interim period. However, I've been in touch with the 3 NHS trusts that will be providing the quality accounts, and with the first meeting of this committee, although the diary of committees hasn't been finalised yet, we're hoping that this committee will be able to meet as early as the 1st of June, so that will fall within the timescales, so we don't need to delegate any authority. We can just bring the quality accounts to that meeting.
Thank you. Steve, do you want to comment on that?
I think that was learning from the previous experiences under the old structure. I think that is far better and more one more democratic and tidier way of doing it. So I'd support us doing that. Yeah, Chair.
Okay, thanks. Perhaps if I could ask if that will be a slight change to how the committee handles those, if members could be sent a briefing, whoever's on the committee next year, before that comes to that first committee, that might be helpful. Thanks. And then we've just got the oh, sorry, I should ask you formally if we're okay with that as a process for the Quality Council. Okay. And then the work programme, I don't think there's anything particular to note on this. I think it's quite organised for the first meeting of next year. There are a couple of items there, including the maternity that's been deferred, and also a couple of separate informal sessions that we've requested. One to look at mental health interventions. That was a request from Councillor Lee to have a discussion space around lower level mental health problems that don't reach the threshold for clinical diagnosis. And I think that would be a really valuable discussion to have. And I think, Mary, you're going to provide perhaps a little bit more as to how you'd like that session to shape up, assuming that you'll be sitting on it next year. I'm making that assumption. We'll see after May. And there's also the session, possibly the first of more than one session, to a primary care workshop to invite representatives from GP practices, including practice managers, perhaps, and the local medical committee, and to begin a discussion about how primary care, to inform us more about how primary care is actually working out in our communities. So that's I've requested 6 sessions to be put into the council diary for this committee to have those informal spaces for that kind of discussion. So that those 2 will form the first 2 of those, I think, in the next year. Anything else that members want to add? Okay, so that's the work programme agreed to pass on to the next incarnation of this committee. And I think, does that bring us to the end of everything? Just to note that the next meeting of this subcommittee is expected to be on the 1st of June, if the diary works out that way. And then to thank members very much for all your contributions throughout the year. To thank Lucy in particular from Health Watch for being a very patient and participative, co-opted member of the subcommittee. I hope you'll come back again and continue your valuable work in informing us. So over and out, I guess, from this subcommittee for this year.